Welcome to this evening's forum, Sexual Health Care for Aboriginal and Torres Strait Islander Patients in New South Wales. My name is Serena, your ICGP representative for this evening. We are joined by our speakers, Dr. Tim Senior, Dr. Annalise Crane, Jess Wilms. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. Our speakers for this evening. Tim is a GP at the Royal Aboriginal Corporation in Southwest Sydney. He's a medical advisor to the RCGP in Aboriginal and Torres Strait Islander Health and is a clinical senior lecturer in general practice and Indigenous health at the University of Western Sydney. And as a GP with a special interest in aviation medicine, she's a Maori woman with family from Maori and Tinga. And our co-owns two large GP practices in the Sutherland Shrine as passionate about menopause medicine and all kinds of families. She's a mom of 3 sporty kids, a Qantas wife, and patrol captain at Cronulla SLSC, where she had a dreadful fear of sharks but loves ocean swimming. Just as a Wiradjuri woman, she's an Aboriginal Sexual Health Education Officer for the Nepean Blue Mountains Local Health District. She co-leads the statewide Aboriginal Sexual Health Portfolio for New South Wales and sits on the working groups for Take Black Tin and Play Safe. Just work alongside community creating safe, inclusive environments. She's passionate about safe and equitable healthcare for all and tackling stigma and discrimination faced by Aboriginal and LGBTIQA+ communities. I'll now hand it over to Tim, who will be going through the learning objectives.
Good evening, everyone. Thank you so much for joining us tonight. I'm coming to you from Darawal country, where the land that I live and work on. These are our learning objectives for tonight, which is essentially educational speak for what we hope to get out of the next hour or so that by the end of this online CPD activity, we should all be able to build our own confidence in delivering culturally safe, respectful and effective sexual health care for Aboriginal and Torres Strait Islander people. We should be able to explore models of care that identify at-risk populations, enhance STI, HIV and BBV testing rates, and equip GPs with strategies for partner notification, contact tracing, and ongoing patient support. We should all be able to maximise the impact of the Aboriginal Health Check MBS item number 715 by integrating it into primary care to improve early detection, prevention and health outcomes. And we should all be able to reflect on epidemiological data and historical context to gain a deeper understanding of the healthcare experiences of Aboriginal and Torres Strait Islander people in our local communities and consider how these factors shape engagement with primary care. And if you move on to the next slide, thanks. Any good medical education talk, we start off with some epidemiology and everyone's heart leaps at the idea of some statistics. But if we move on to the next slide, it's really important as I've learnt this as a non-Indigenous GP that it's very easy for us to start thinking about Aboriginal and Torres Strait Islander health as if it's just a collection of diseases and bad statistics. And the thing that I've learned is that we start asking the wrong questions. And actually, when I'm showing these statistics that inform what we're doing, there are reasons behind that, and it's not until we sort of understand the reasons and that we listen to our Aboriginal and Torres Strait Islander colleagues and our Aboriginal and Torres Strait Islander patients that we start to understand the reasons behind the statistics, and that's when we start to actually improve what we're able to do. So I sort of raise that important context, I think, in the statistics that we're about to go through, and for the webinar tonight as being the non-Indigenous person facilitating the panel tonight. So if we move on to the next slide, this is the population of Aboriginal and Torres Strait Islander people across Australia, and because we're the New South Wales faculty, we've highlighted the New South Wales faculty numbers. So there's the highest proportion of Aboriginal and Torres Strait Islander people live in New South Wales, and actually it's 35% of the Aboriginal and Torres Strait Islander population who are in New South Wales. The second highest is in Queensland, and so in absolute numbers, at extrapolated from the census is close to 340,000 Aboriginal and Torres Strait Islander people. The meaning for that is that they're not all living in one place, and that wherever we are, we will have Aboriginal and Torres Strait Islander people in our communities, and coming to see us as patients. That's important for us to recognise, and identification of those people is really important because it affects our clinical care. If we move on to the next slide. So this is the notification rates for different STIs and bloodborne viruses. And it compares Aboriginal and Torres Strait Islander people and non-Indigenous people. And then because of the different age rates in the two populations epidemiologically, it standardizes that according to, and then sets it out as a rate per 100,000 people. And so you can see the rates there for chlamydia. You can see it highlighted in red there, but I'm also going to concentrate on the fold difference. So for chlamydia, it's twofold higher in Aboriginal and Torres Strait Islander people. Gonorrhea is fourfold higher. Syphilis is nearly 5 times higher in Aboriginal and Torres Strait Islander people. HIV and hepatitis B, much closer to similar rates, but newly diagnosed hepatitis C is over 6 times higher. Now, the important thing about that is that the rates are much higher than we'd expect per 100,000 population. The absolute numbers are higher in the non-Indigenous populations simply because the numbers of people in those populations are higher. So again, this is why it's important for us to identify our Aboriginal and Torres Strait Islander patients, I think. Move on to the next slide. Again, this goes on age standardized STI notification rates. This is nationally, so I think the previous one excluded some jurisdictions. And syphilis is a real standout there, as nearly 5 times higher in Aboriginal and Torres Strait Islander people. Still, chlamydia is twice as high and gonorrhea is 4 times as high. So it's really important that we're identifying this. The next slide shows the main reason why syphilis is so important, because the consequences of congenital syphilis are so high. And this shows over each year since 2019, the cases in Aboriginal and Torres Strait Islander people of syphilis reported, and in non-Indigenous people. We can just see the numbers have gone up each year. Now, the absolute numbers aren't high, but that's a significant increase. And that will keep on going up if we're not identifying those patients. And we'll be saying quite a bit today about how we identify, and that's partly testing, but it's also giving the conditions that in our practices that people feel comfortable seeing us and talking to us and being tested. If we don't do that, these numbers will only go up because, of course, it's sexually transmitted. If we move on to the next slide. So again, this is an interpretation of that those increases, along with a considerable increase in the number of congenital syphilis cases. And that's really important because the consequences of congenital syphilis are huge. And that emphasizes the need to enhance culturally appropriate health promotion, testing and treatment strategies in partnership with Aboriginal and Torres Strait Islander stakeholders and communities. And that's part of what we're doing tonight. Those numbers go up when people don't feel comfortable accessing healthcare and also education, when people are unemployed and live in poverty and experience discrimination and racism and expect that they might experience discrimination and racism. People don't go to get tested. They don't trust the treatment. And so those figures keep on increasing. So while we're providing clinical care, it's really important that we acknowledge those social circumstances that people live in have an impact in the way they're relating to us and the way they're choosing to seek care. And in the bottom line for me is that every Aboriginal and Torres Strait Islander person in Australia should be able to choose to access care wherever they want and be confident of getting good care. So move on to the next slide. And so I'm going to hand over to Annalise to start us off on discussing some of the solutions to the surface statistics that we've just seen. Thanks,
Tim. So as I was introduced, I'm a GP in Southern Sydney, and most of us listening here today are also GPs. So I want you to think about your practice and the cohort of patients that you see. And if you see 100 patients in a week, it's highly probable that 2 or 3 of those patients will identify as Aboriginal and or Torres Strait Islander. You may have a family in your practice where you might see the mum, someone else might see the dad, someone else might see the kids. How are you bringing all of that care back together? It's really important to look at, as we've said, making sure those patients are identified and that box is ticked. Do they identify as Aboriginal? Are they signed up to CTG? Are they signed up to the practice incentives for your practice, so that you're able to provide them with the best model of care to service their needs? Next slide, Serena. So I'm going to introduce you to a case study that hopefully you can relate to in your practice. Some of you might do GP shared care. This is a patient that I have concocted up, but also comes from experience of patient experiences that we've heard about. So you've got Janelle. She lives in Sydney in the inner west, and she's a 32-year-old professional. She's presented to you 8 weeks pregnant. She's asked to birth at RPA Hospital near Newtown there, and she wants to do shared care. So this could be any one of your patients. It could be any of your shared care patients. When you encounter her as this 32-year-old professional with her first pregnancy, what would you do differently if she was Aboriginal? Next slide. So my question to you is, if that woman was sitting in front of you, would you know what to do differently? Would you need to do anything differently? And how are you going to offer her culturally appropriate care? So I think firstly going, right, I can provide shared care. I'm good at being a GP and doing that, knowing what your capabilities are. And then looking at, right, she's going to have her initial lot of screening antenatal bloods. Do you need to do anything differently for her? Everyone who presents gets tested for syphilis. Not everyone necessarily may get a urine chlamydia and gonorrhea. Does this woman need it? What other services in your local community could you link this woman up with? For example, did you know that RPA has a specialist program for women who identify as Indigenous to be managed within RPA Hospital, a little bit like group midwifery practice, where they may see the same team of midwives throughout their care, or those midwives are able to link them in with other services down the track, such as early childhood services, allied health and other things that they may need. It's knowing what is available to you locally. But also, I think the stop point here is, don't just assume because she's Aboriginal that she does need something different, but because she's Aboriginal, it's possible that she may have a different risk profile. Next slide. So before I flip the script and we go a little bit rogue, just think again back to Janelle, and perhaps it's a good opportunity for you to think about this for your Q&A later. If you saw Janelle in North Sydney, or you saw her in Penrith, or you saw her in Cronulla, what would you do for her in that initial consult that's different? Would you automatically assume she was a high-risk patient? She might be the principal of the local high school. She might be a nurse in your local area health service. How does she present compared to every other 32-year-old antenatal patient that you've seen? So we'll go through some of those scenarios in a little bit more depth soon. But I suppose what I'm going to ask now is, if Janelle was male, what would you do? Of course, probably wouldn't be presenting for antenatal care. But if you had a 32-year-old professional who identifies as Aboriginal and Torres Strait Islander and they were a guy, what may you need to do differently? I suppose in my practice, I offer STI screening to everyone under the age of 30 should have a test at least once a year, if not twice a year. If you've got high risk patients who are having multiple sexual partners or they're employed in that industry, they may need to have more frequent tests than that. Similarly, if Janelle happened to be a gay male, what would you do differently? Would you offer syphilis testing whether he was Aboriginal or not? We've certainly looked at the numbers that Tim has discussed and identified that, yes, the raw numbers show that there's increased risk, but you need to make that reflective to your practice and your community and the cohort of patients that you see without assumptions and presumptions there. Next slide. So I think this is really interesting again. So as in, I work in a private billing normal general practice. Tim works in an Aboriginal medical service. Jess works in a hospital health service, more of a community setting. So therefore, who we see, our patient demographic is slightly different. But what isn't different is how we communicate with our patients, how we explain to them what to expect when you're expecting, what to expect out of that consultation. And of course, it's respect and rapport and making sure the patient is in control of their own journey. And that could be, Janelle, you're pregnant. As a part of your routine antenatal testing, we'd like your permission to order these STI tests. That will involve a blood test and a urine test, and all of the women in New South Wales are offered these tests. It's about protecting you and protecting the baby and able to offer treatment if necessary, because we have certainly heard of scenarios where tests were provided to the patient and there was no informed consent. So patients were just assumed to be at high risk, and therefore additional tests without any informed patient involvement were made. And I think also looking at how do we improve birth outcomes, antenatal outcomes, general women's health by including them in that process and explaining it in a way not everyone understands transmission of STIs. We don't know the dynamics of people's relationships. And again, we don't know the type of relationship people are in unless we actually have that conversation. And a GP is best suited to do that. I would argue we know our patients well once we have that established relationship with them. And similarly, if Janelle was a male, what assumptions are we making? Are we assuming Janelle's gay? Are we assuming Janelle has one sexual partner? Next slide, please. So I think, is this the bit where Jess is going to start to talk, or is this still me? And then I'm getting stone cold silence from Tim.
Yes. I was looking at my order. Jess, were you expected to talk about that now?
That wasn't me.
No, we'll flip that one and we'll come back to it. But of course, some of these future slides are looking at how we notify people, how we communicate that information and how we set out those expectations. And I'm really hoping that Jess is now going to take over and know exactly what these next slides are about.
Don't know if she was, but we were going to go over about the importance of contact tracing and patient referring for that. And I think there's all of these different resources that can do that. So Drama Down Under is really geared towards men who have sex with men, and so it sort of communicates in that way. There's Let Them Know, which is a sort of a fairly more generic one. For the purposes of what we're talking about today, Better to Know is really excellent for Aboriginal and Torres Strait Islander people, sort of set up for that. And that allows people to notify partners that they've had by SMS text message without the partner necessarily knowing who it is who's sent it. So those are really useful tools for us as GPs to enable partner notification to happen. And I think on the next slide is so the sexual health info link. Now I've come across these people before, and they're really helpful, that if we're feeling a bit stuck or not quite sure what to do, or difficulty with contact tracing, they can give us sort of advice on doing that. And I think we're all from Sydney, but so that's quite metrocentric, but the sexual health clinics, and particularly the sexual health info link, are able to provide advice when there's not a sexual health clinic anywhere near you, might not be any specialists near you, and that's a really good resource for people to be able to do that.
Especially if they're for infections that you may not come across very frequently. I know that earlier in the year, in one of my other job roles, we needed to do some test and treat for Mpox. And of course, that was something that I wasn't necessarily familiar with in a suburban setting. However, we were able to speak to the public health unit and speak to our local Short Street clinic to be able to get the advice, and then also to order in the vaccines and be able to provide that service.
Yeah, absolutely.
Let's see what the next slide is.
I know what the next slide is. We'll pass on to Jess.
Warrami, everyone, from Darug Land. I am Jess, a proud Wiradjuri woman. I am an Aboriginal Health Education Officer within a local health district, so work for New South Wales Health. So I'm going to talk a bit about 715s and how we can utilise them to get better outcomes for Aboriginal people when it comes to sexual health. And next slide. So 715 health checks are a great way for people to access sexual health screening in a safe space. They're an annual holistic health check for Aboriginal and Torres Strait Islander people, and they're very normal and embraced within Aboriginal communities. Often mob are really embarrassed or shamed to go and get a sexual health screening. So building it into their 715 is a great way to take the pressure off them and to try and engage them in services. The 715 is a preventative health measure. It focuses on having a proactive health behaviour as opposed to a reactive one, which is often what we see when it comes to sexual health. And a really good opportunity for practitioners to promote regular STI testing between 715s and link it into their 715 so people can go back under the guise of getting a general blood tests, that kind of thing, without them needing to disclose that they're getting a sexual health screening. Therefore, it removes the stigma around actively seeking testing and allows for that regular monitoring and provide pathways for additional services. So in the 715 screening here, when it comes down to the sexual health question, it is there anything you are worried about in relation to your sexual health? Yes or no? So that question's quite vague, and in my view, not a very strengths-based way of asking about people's sexual health. Sex, sexual health, contraception, all those kinds of things are very uncomfortable topics for a lot of community. And so you need to go out and explain the questions and explain to people that those questions are going to come up, and letting people know that there's no right or wrong answer, that they're not going to get it wrong, that they're not going to get into trouble, and that it's not mandatory to answer to complete their 715. I think a lot of the time mob think that they need to answer everything because, you know, health systems are seen as a very punitive kind of measure in a lot of communities. So we need to make it really safe and really clear that people can answer what they are comfortable with. And I think Annalise went into this a bit, like giving context to why you're asking questions so that you can get as much information from the health assessment as you can, and explaining that it's completely confidential, and that practitioners can give some of those details on ways to refer people to more culturally appropriate services if they feel that that's necessary. Next slide. So there's a lot of resources out there for GPs when it comes to 715s. So pictured here are a couple that have been done in conjunction with NACHO and the RAC GP. So they give you some information on how to be a bit more culturally competent, how to ask questions, what's required when you're doing a 715. And there's also some information here you'll see on the right from the health.gov.au kind of services. So you can look at those at getting some more information. And there's a few more on the Gov website that are really great as well. Next slide, please. So there's many resources that you can access when it comes to Aboriginal sexual health. So I'm just going to cover a few that I use quite regularly. But if you do a bit of a Google deep dive, there is plenty out there, not only from New South Wales, but also other states that are really relevant. I saw something from Shine SA in an earlier slide, which have great resources as well. So we've covered Better to Know as somewhere where we can use for contact tracing, but they also have really comprehensive sexual health information. And as you can see here on their website, they cover 715 health check stuff specifically. They also have a Remind Me page, which can get people to put their phone number in and they get a reminder to let them know that it's time to go and get an STI check, which is a great option for a lot of people that can't actively remember that they need to do those kinds of things. There's also service directories for sexual health info, for AMSs, HIV support services, all that kind of stuff. And they also have a really great resource page for national resources. So for mob that's not based in New South Wales, but might be accessing services within New South Wales while they're here, gives you some options on where to refer people interstate. In the middle here, we have the Aboriginal Health and Medical Research Council's printable resource that comes from their Doing It Right training. So that's training specifically around really extensive options for people to know how to do sexual health conversations, screenings, all that kind of stuff. And you can download this resource. It has a lot of information in it. It's a pamphlet, so it covers a lot of different topics, really well done, and it's done by Aboriginal people for Aboriginal people. So it's a really great option if you have a client that maybe needs a bit more information, needs a bit of time to go away and think about things. Also, people that are just not keen to have a chat. It's great to have those options just sitting around so people can access them. On the right here, we have some research done by Dr. Heather McCormack, who is a research fellow at the Kirby Institute at UNSW. Heather did her PhD on optimizing annual routine health assessments to increase testing for sexually transmissible infections and HIV in Aboriginal and Torres Strait Islander young people. Her research is centered entirely around how 715s are vital to improving the sexual health of Aboriginal young people, and also this information can be provided in context for Aboriginal adults as well. It is perfectly placed to help you gain further knowledge and insight into how you can do it well. You can find her articles and her papers on her UNSW page or on her website, which I've linked in a later slide. Next slide, please. So PlaySafe Pro is something that we provide a lot of kind of information about in the services that I do out in community. It's something that we push really hard for people to have a look at because it's done by people that work in sexual health all day, every day. It's about making sure that we have options for all kinds of workers that work with community, young people, that kind of thing. So PlaySafe Pro has this checklist here, which is a youth-friendly checklist, which is for general practitioners. And it's a tip sheet on how to ask sexual health questions in a casual, relaxed kind of way that's going to help engage young people. Many of the tips on the sheet also work for mob, and part of it is about making physical spaces more welcoming, about looking at your cohort and figuring out how you can make your space less clinical and less sterile. Ways you could do this for Aboriginal people is perhaps having an acknowledgement of country on your wall or on one of your screens, looking at putting up some artwork, that kind of thing. It's about showing genuine care and compassion for your mob, from the reception staff to the doctors and nurses in your practice. It's about knowing which of your patients are Aboriginal and knowing more than that, who their mob is and what does their family look like. This is not a performative exercise. The whole practice needs to be culturally appropriate. More damage can be done by than good can come from well-meaning but poorly executed endeavours. On PlaySafe Pro in the middle here, you'll see Take Blaction, which is also a service done by Aboriginal workers for Aboriginal community. You'll see here a fact sheet which literally walks you through, I think there's 10 steps on it, about engaging with Aboriginal people. So it's about knowing people, asking them who their mob is, finding ways to have those conversations in a really culturally appropriate way. There's a step-by-step guide on working around sexual health with mob. It includes things like, do your patients want an Aboriginal health worker? Would you know where to access an Aboriginal health worker? Is there anything that is culturally inappropriate to be done in regards to men's and women's business? Do you need to refer that person on to a different GP so that their sexual health needs can be met in a culturally appropriate way? All these are questions to ask of your patient. No two people are the same, so you need to find out what works for Mob. What happens in Sutherland might not work out in Penrith. It's about each community, each person being different. They need to lead this, and it's about being respectful and curious. You're rarely going to receive a complaint from someone because you tried to meet their cultural needs, but Mob will speak with their feet if they do not feel safe in your practice. Start by finding out who they are, who their family is, and what that looks like for them. We are people, and we're not a ticker box. I'd be really interested to find out who remembers who my Mob is from the start of my preso, and also where I live, because I acknowledged both of those at the start. Down the side here, you'll see a bunch of resources that I've spoken about, and I'd love for you to take a look at the Take Action page. There's a video tab up the top where you can see a bunch of videos and skits done for community by the Ministry of Health, done really in a really fun, humorous kind of way, which is how we engage with people. Looking at the resources that they have on PlaySafe Pro, there's so many things that are great. 144 free condoms for your practice each month, all those kinds of things. Trauma-informed care booklets. We have a Talk Soon, Talk Often booklet, which can be put out in waiting rooms about talking to children about their bodies, puberty, sex. There's a Yarning Quiet Ways one coming soon, which is an Aboriginal version adapted from WA. There's lots of different options that you can put around your service to make sure that it's more culturally appropriate and welcoming. Next slide. Finally, this is a piece of art that was done by all the Aboriginal sexual health workers from across New South Wales. We get to come together once a year from across the state and talk about what's important to our community and what we need to do to have better health outcomes for our community, which is how this came about for me being here tonight, is that we have a representative showing you what we need and how we need it. Every health district in the state has a sexual health, bloodborne virus and STI team. And within those, a lot of them have an Aboriginal worker like me. If you need any answers or you have any questions, all you need to do is reach out. We are there to help you do this better, and we are there to help you to know where to start. My contact details will be at the end. So if you have anything that you want to ask me, please feel free, and also in the chat box. Thank you.
Excellent. Thank you very much. That was really good. I think so we're going to move on to a panel discussion where I fire questions at Annalise and Jess now, where we bring all that together about how we use 715s. We'll think about Janali and some people like Janali in working out how we actually put this into practical action. And I think as we go through this, think about your own practices and your own communities and what might work in your areas, whether you can steal ideas from other people. And because I think all of this has to be localized. It's about knowing our own communities. So we'll move on to the next slide, and at some point as well, Serena, we might pop back to the some of the questions that we had about Janali as well, because I think that'll inform some of our discussions. But I'd like to ask Jess first, actually, from what you know about the way that the contact you've had with people across different sections of the health system in talking about sexual health history. What are ways that we as GPs can do it better?
I think asking, giving context to why you're asking the questions. I think people will go in having some knowledge of what an STI or BBV test would be, but probably wouldn't have the context of history taking, all those kinds of things. So I think it's about explaining to people, we don't want to know everyone you've slept with. We don't need to know all the details, but we're just trying to get a bit of an idea about what, what's been happening, what kind of tests you're going to need, that kind of thing. I think it's all about providing as much knowledge as you can to people, because a lot of discomfort and shame comes from fear of not knowing what's coming. And so I think giving good information and providing that before you start asking the questions is really important.
Absolutely. Annalise, how have you found what you've heard from patients? How can we improve doing this as GPs?
So I've just lost the entire Wi-Fi in my whole house. So I'm now running off my phone. And of course, my children are screaming that the internet has gone off. So I've just missed the whole last 5 minutes and have no idea where we are. But I think looking at this question in front of me, looking at the context of who's sitting in front of you and what you think is clinically appropriate at the time. For example, the 32-year-old professional may not need high-risk screening at regular intervals throughout her pregnancy if she's in a monogamous married relationship for the last 10 years. But again, knowing that it's an open door where they can come and ask questions and have appropriate tests, for example, when they present for their self-collect HPV screening, saying we offer all women the opportunity to do a urine PCR or a swab, or all of our men may be offered XYZ, knowing that that relationship goes back and forth between both of us.
Thank you. Yeah, so I think what you both said, there's some themes I've really picked out from what you both been saying earlier as well, and I'm really struck by being aware how often people have had a bad experience in the health system before they come and see us, and that seems really common. And that they often come to us expecting another bad experience. And so if we're aware of that, then we can do everything we possibly can to say, look, I understand that, and I will make this experience not a repeat of your bad experiences. With STIs, often it's quite secret stuff, so they're only seeing us. And one of the advantages we have in general practice is they're sat in our waiting room, and auntie comes in and go, oh yes, I'm just coming about my sore elbow, and then come in and ask about the discharge that they've got or the whatever. But if you sat in the waiting room of a sexual health clinic, everyone knows why you're there. And so I think we have this advantage in general practice of reassuring people about confidentiality, but no one can guess the reason that people are there, which means that they can come. And the other thing that I took from one of the things that both of you said is that this giving information beforehand, this making sure you get consent and explaining the tests and things, is allowing people to have control over their own healthcare and their own decisions. Too often people are sort of bounced into doing, well, you've got to do this. And the case of Janali, I sort of feel she's going to be in hospital or coming into contact with midwives who may well say, no, you're Aboriginal, you've got to do this. And to some extent, we have to, when we're making those decisions, we're also protecting people from the rest of the health system making different decisions. And sometimes I say to my patients, look, they're going to annoy you in the hospital. Don't fight back, don't answer. Come back to me and moan in my consulting room. Come back and have a shout and with me, and come back and just moan about it with me. But we'll be your release valve for that, just because we know that can happen. And this idea of allowing people to keep control over their healthcare as they go through it. And I think I've learned, again, as a non-Indigenous person, and this will be different for Annalise and Jessica, because both of them, they'll be able to say things to patients that I can't get away with, where people like me in positions of power, non-Indigenous people, have been telling Aboriginal people what to do for over 200 years now, and it's rubbish. So giving people that control is actually really important. People understand that historical context. But Jess, I'm sure you can say things to patients about, well, no, you really need this test done, get in and have it done, that I would actually just have people walk out if I said that to them.
And I think it's hard in the hospital system, like you're completely right, is having an advocate that knows you and knows your needs and knows your context, because you do walk into a hospital and you have the little flag pop up, and so you aren't asked for consent, and you aren't asked your history or treated as a person, you're treated as a number. So I think that is the advantage of accessing a GP for community, we talk a lot about accessing, like you work at Tharawal, so a lot of mob often are reluctant to go to an AMS because they have family there, have all that kind of stuff. And even though you can tell them that their information is confidential, it's still a worry.
Absolutely.
So that's why events like this are amazing, to try and upskill general GPs to be a safe space for mob to go to, because we don't want them having to go to a sexual health clinic, because it's not a positive experience a lot of the time.
Absolutely. And I think the other thing, finally, just on this question, what you were saying, Jess, about the importance of Aboriginal health assessments actually makes taking a sexual health history easier, because we can say, look, we're testing over your whole health. That includes your sexual health as well. We ask everyone these questions. And so, do you mind if I just ask you these questions too? And it normalizes it, that this is a legitimate part of the consultation, that we ask everyone as part of preventive health. So if that's all right, we'll do that. It doesn't look like prying, because it's part of a health assessment. So that gives us another opportunity to ask those questions and make it a normal part of asking.
Yeah.
If we move on to the next slide, Serena. This is moving on to talking about the results that we get with patients. We can, for some of those, for a patient, often a positive result for an STI or for a bloodborne virus is terribly bad news. Any advice for how we go about giving those results?
I'm just going to start that 20 odd years ago, I worked in a small riverina town near Griffith, and was given bad news over the phone on a Friday afternoon as a young person. And it's actually probably part of the reason why I decided to become a doctor, so that nobody else would ever have that experience ever again. And it was like the perfect storm. And I think most of us as experienced GPs know how to set that groundwork, but it's been really interesting to observe our registrars in our local community as well. And those skills don't come naturally for some people. And so the classic starting point is, if you order a test, make sure the person understands what the result may mean. And my colleague who's also listening in here tonight, the patient walks out of the door knowing, I will contact you by SMS, by email, I will phone you, I will schedule you an appointment. Or you're having a test on Monday, come back and see me on Thursday, so that you know they're going to receive that information on Thursday in front of you when that's what they're coming for. And I think, of course, if you're telling someone they've got chlamydia versus you're telling someone they've got syphilis or HIV, we don't know how they're going to understand that, because we don't know what their health literacy is. We don't know what their past experiences, family experiences are with those diseases. And of course, I was actually speaking to a patient on the weekend who works as a remote area nurse in another state. And she said, we literally chase people into the bush to try and go, we need to treat you for this infection. Please come into town, please. Or she's providing that service on the ground in the community. And of course, we're lucky in New South Wales, we have buildings we see most of our patients in buildings or even in gardens and outside environments, but we're probably giving them penicillin for syphilis inside. So that context is really important. And again, setting it up, if it's an antenatal patient or it's a mother, going, this is for you and your family. That mantra works well, going, it's not just about you. It's about your kids. It's about your ability to care for your family. It's about your relationships and your job and your social responsibilities. So it's not just, you're a bad person, you've got syphilis, we need to give you these large needles in your bum. It's, if we test and treat now, this will stop it in its tracks. And clearly that message is being watered down a little bit because we've got increased cases of syphilis. But it's also looking at, does anybody know how much these medications cost? A week of doxycycline versus a month of doxycycline versus Ben-Pen injections. They're all luxuries if you've got a pharmacy nearby or you're working in an AMS where those medications may be provided as a part of the service. And even if they're signed up to CTG where they're getting discounted PBS medications, they're not always going to have $10, $20, $30 to be able to return. And one of the questions in the Q&A box is, well, what about the transport to get to the service? Where my practice is next to a train line. So if you don't have a car, you can get there. But if you have a disability and you need to come with a carer, you have to line it up on a day that they can bring you. There's often logistics that we don't think about once the patient sits in the little box that is our consultation room.
Specifically on the transport one, at Thurrock, so Aboriginal Medical Services often offer transport to their patients. The Aboriginal chronic care teams in your local areas, they often offer transport to patients to appointments. And sometimes there's community transport. The Gadangara Land Council in Liverpool do transport for many of our patients too. There's, in our area, we have Southwest Community Transport, where for a fee of $2, you can sort of book and get that. And so many areas across New South Wales will have similar schemes to that. We often don't know about those, but it's worth finding out why transport is a particular issue. Sometimes in rural and particularly more remote areas, there are patient travel programs. Sadly, I'm more familiar with the ones in the Northern Territory than in New South Wales, but I know they do exist. And finding out about those from your local health district will be really useful as well. So there are solutions to those problems, but they often take a little bit of digging just to get to the local particular solution, because they often arise from local need. And thank you for answering those, because that was really useful. One of my favorite bits of evidence is that if you explain to people, not specifically for STI testing, but if you explain to people the potential results of a test before you do the test, and particularly of a normal test, then that actually allays anxiety more than explaining a normal test result after the test when they get it. So actually, I very often explain the test and the reasons that we're doing it and the results that we expect and what I expect to get from that, so that sort of people are primed in advance for sort of those expectations. If we move on to the next slide, just want to ask you, Jess, what do you think's done well and what's done poorly in sexual health particularly?
I think coming from a health promotion kind of background, I think health promotion is not done well, which is why I have a job. So it's about looking at ways of communicating health messaging in a way that works for community. I think a lot of the time it comes from a medical background, those kinds of things, and community just do not understand what you're trying to tell them. So it's about linking in with services. If you have a cohort of patients and you're like, what is happening? Why, like, do we have this huge pocket of syphilis? Like, we have that where I am, we have a pocket of gonorrhea at the moment. It's like, well, why isn't that messaging getting through? So it's about trying to link in. And I think medical services and health promotion and all those kinds of things, we're all siloed and we don't work well together. So it's about finding ways, linking into the PHN. I know we're always throwing things into their newsletter, but really utilizing the services that are around. I think we don't do that well enough. And getting out into community, like if you work in a community that has a high Aboriginal population, go out to NAIDOC, go say hello to people, because it will do so much groundwork to proving yourself in community and showing that you genuinely care. I think you're then going to have better outcomes for your patients by doing something that you think is not important, but is very important when it comes to Aboriginal communities.
Totally. Thank you. Annalise?
I think it's worth acknowledging that immunisation rates in Aboriginal communities in New South Wales are actually very high, around 94 to 96%. So if you think of that in terms of, say, Gardasil for prevention of cervical cancer, or other HPV in general, there's also lots of emerging projects coming out in the next 12 months about prevention of and treatment of anal cancer. And so by knowing that if the kid in year 7 is receiving their Gardasil, that's a preventative strategy that New South Wales is currently very good at for patients who are Aboriginal. I was also involved in the rollout of the HPV self-collect cervical screening. Again, it's another measure where the uptake of underscreened or never screened Aboriginal women has increased like over 50%. So by listening to community and going, why don't you want to do this test? It could have been a trauma experience. It could have had a negative encounter with the health service. However, if we can go here this swab, do this to it and give it to the lady at the desk or chuck it in that basket, no one's going to talk to you, no one's going to touch you, it increases that uptake. So in the same way, if some practices might have urine jars on the counter or in the bathroom, they do that at RPA in the antenatal clinic. So you can then go to the nurse's station and going, oh, here's my sample. Can you do a chlamydia test? Can you do a gonorrhea test for me? So it's again looking at what's the barrier and how do you overcome it? And in your normal mainstream general practice, there's little tiny things that you can do. Even having the nurse break down, if you're an older male GP, you may have a female nurse that sees the patient first and goes, I'm just here to check your blood pressure. I'm just here to do something. It's that segue into, is there anything that you want to tell me? Is there anything that you'd like me to bring up with the doctor that you don't feel comfortable talking about?
Yeah, I think that's excellent advice. It's worth us remembering as GPs that we can be really proud. We have excellent communication skills, and those don't desert us when we're seeing Aboriginal and Torres Strait Islander patients. So we just have to be aware that patients have often had bad experiences and use our communication skills to the best. We are still highly trusted as a profession, including among Aboriginal and Torres Strait Islander people, and so I think that's worth remembering. And as I say, that general practice is a great place to do sexual health testing and sexual health discussions, often because we are trusted and because people can't guess what they're there for. We've had some good questions come through already, and I think we've got 8 minutes left, so I think it's worth moving on to Q&A if you want. And one of the things that I'd like to start with was a question that Timmy's already answered in the text, but I think is important for us to think about because a lot of people worry about this. Do you have any tips for patients who are lost to follow-up? Beth?
So hard. We spend a lot of our life chasing people. I think I think I saw another question too about mobile patients and people that are only in the area for a couple of days. And I think it's really important to gather some information at that kind of point about where they may be next and how is the best way to contact them. I know we do a lot of inter-service agreements, that kind of thing, finding someone that knows where they are and getting permission while they're in front of us to be able to contact them so that, you know, if they are out in the bush, we can call the AMS out there and they can go find them, that kind of thing. I think it's about thinking about that in the moment and building that into the questions you ask when you're screening them.
Totally. I know for myself, when I know I'm going to be needing to specifically check out that result or something, I'm asking patients permission, I'm checking that their address and phone number and email are right and up to date and seeing who they can ask. We're really lucky in having Aboriginal health practitioners work with us who again can say things to patients and know the community so well that they can go and they know who they associate with, where they hang out, who their family members are, and can go and find them in a way that isn't found offensive. Whereas if I was going hunting them down, they're going, what are you doing here? That's weird. And so we're really lucky in having that as a resource, I think.
I think it's really interesting to also consider if you were chasing someone, you may call their emergency contact or their next of kin. And in this case, that result may be unknown to that person, or you've got a teenager and you're going to ring the parent. Or similarly, thinking if you disclose that there may be some coercive control or some domestic violence involved, and therefore that's one of the reasons that this patient is avoiding follow-up, it's often more complex than they just didn't know and they didn't care. So again, using those community opportunities, even as simple as the patient may have an appointment in a hospital service, but perhaps in our referral going, if you see this patient, can you please make sure that they make contact with us, or having some shared communication to be able to say, we need to treat this patient. It's a part of their holistic care. But of course, we know people aren't completing or compliant with all aspects of treatment. Otherwise, we wouldn't be seeing exponential growth in case numbers.
And I think often just finding out in advance who would you like us to contact? Is there anyone that you wouldn't like us to contact in those circumstances? Follow-up question come through as well. Will you catch a patient in a marketplace or a shopping centre who's non-compliant with appointments and the matter is to be addressed seriously? Jess, would you ever do that?
Probably not. But I would potentially just like have a casual wave of like, oh, we need to catch up. Can you come in? You need another test or something. Like, I would just make it really vague, but I would make sure that, you know, at least said hello, that kind of thing, so that they knew that we needed something.
And again, I think you're probably in a slightly different position to myself and maybe Annalise as well, where I know our Aboriginal health practitioners never feel off duty. Like if they're in a shopping centre, that people will ask them about their health and stuff. Whereas I don't get that. I get time off, but Aboriginal health practitioners never do, being part of the community. Got a interesting question here as well. Is there a mentor or buddy system for patients who need more guidance about their healthcare, especially on sexual health, including teens? So they've got a teenage male who's reluctant to engage because they want someone familiar to answer their questions about the health system and reassure them.
It's like the classic 17-year-old girl who brings her friend with her for her Marina insertion, or for her, oh my God, my boyfriend on the weekend said he's got chlamydia. So then they all come in together. Men don't do that. But I certainly don't think there's a formal system of having someone come. However, like AMS would certainly welcome in the Aboriginal health worker to the consult if required, or conduct the consult and perhaps invite a nurse to come and provide that cultural link. In southern Sydney, we do not have any service like that where someone can accompany them. However, we've got we have a sports high school in our area that has a high proportion of Aboriginal students who come and live at a hostel. So they're living away from their local community. They have like the nana in the hostel who may accompany them. She won't go in, but she might go and take them or broker some of that information. Or similarly, if they're involved in, so we have the Clontarf program that school is also involved with, they may have a youth worker or a person who may accompany them. Even so, their sports coach type person would certainly be in a position to support with a phone call, but not necessarily provide structured formal advice.
I do know that, and it may be that one of the people behind the scenes can help us answer this, but Asham have some peer sexual health workers from all sorts of different communities represented in New South Wales. And they're often, I've worked with some in the past, and they're often really knowledgeable, their lived experience, they know exactly what they're doing. And I don't know if they're the sort of people who might be called on to guide some of our patients, that we can put them in contact with Asham to do that. Certainly I'd rely, a couple of things, I'd rely on our Aboriginal health practitioners because they're really good. And despite my white hair and elderly appearance, I would do everything I can to have a what we call a strengths-based discussion with someone like this, where we're talking about what their strengths are, what they really enjoy doing, what they're worried about, and be that doctor who's like showing a real interest in who they are and what they enjoy, not just hey, where's the discharge coming from your dick? Like it's that just becomes this really human interaction. They go, oh, that's someone I can trust. I'd go all out to do that. We've got a few more. Just comment Ashram is a great place to start. We've actually hit 8:30, so we are at our limit. And I think I am keen for you all to get back to your families and enjoy.
Put your pajamas on and eat
rest
your
of the
Easter
evening.
eggs.
Yeah, oh gosh, yes, indeed. So if you do have any other questions, I'll pass back to Serena because she's going to give you an email address that you can use and also the details about the evaluations that you can do.
Thanks, everyone. I'd like to extend my thanks to Tim, Anna, and Jess for presenting, and also everyone who joined us online. We do hope you enjoy the session and that also you enjoy the rest of your evening.